Hello and welcome to the second NCCN Global Policy Webinar this year, The Impact of Climate on Cancer Care Globally. My name is Katy Winckworth-Prejsnar, and I'm the Director of the Global Program here at the National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading academic cancer centers dedicated to improving and facilitating quality, effective, equitable, and accessible cancer care. Through the leadership and expertise of clinical professionals at NCCN member institutions, NCCN develops resources that present valuable information to numerous stakeholders in the healthcare delivery system, most notably the NCCN Clinical Practice Guidelines in Oncology. The library of NCCN guidelines now covers 88 different guidelines, which feature over 228 algorithms and cover about 97% of cancer incidences worldwide. The majority are disease-specific guidelines, but there are also supportive care, detection, prevention, risk reduction, as well as guidelines for specific populations. The Library of NCCN Guidelines is utilized throughout the world. We have nearly 1 million registered users from outside the United States, and last year, over 7 million guidelines were downloaded ex-US. As you can see from this heat map, NCCN guidelines are accessed in nearly every country around the world. NCCN appreciates and recognizes the supporters and sponsors for this series. Without your support, this webinar would not be possible. Thank you. Today's program will focus on the growing challenges that climate change poses to cancer care delivery, particularly how extreme weather events like wildfires, droughts, and tropical storms are straining supply chains, hospital systems, and patients' access. These disruptions can delay treatment, limit transportation options, and compromise outcomes for vulnerable oncology populations. Our speakers will discuss how this landscape has shifted, progress as well as barriers, and how we can build resilient, patient-centered solutions in the face of a changing climate. The program will begin with a presentation from Dr. Joan Schiller, who will give an overview of how climate change impacts cancer care delivery systems. Next, we will hear from Dr. Zorana Anderson, who will discuss environmental exposures and climate change from a policy perspective. We will then host a live panel discussion focused on these topics in much more detail. Our moderator for today's webinar is Gary Way-Miller. Gary is the Executive Vice President and Chief Operating Officer at NCCN, and we are thrilled that he is moderating today's session. At this time, allow me to briefly introduce our two keynote speakers. Dr. Schiller is a renowned lung cancer researcher and passionate advocate for climate-related health equity. Dr. Schiller earned her MD from the University of Illinois and completed residency at Northwestern Memorial Hospital. Dr. Schiller chairs the Oncology Advocates United for Climate and Health International, a global nonprofit educating oncology professionals on the health impacts of climate change. With over 200 peer-reviewed publications and leadership roles at top cancer centers, she brings decades of expertise in clinical research, academic medicine, and national advocacy. As the founder of Free to Breathe and a board member of the Lung Cancer Research Foundation, her voice has shaped both science and policy. Today, she inspires us to connect oncology with climate action. Next, we will hear from Zorana Anderson. Dr. Anderson is a global leader in environmental epidemiology and public health policy. As a professor at the University of Copenhagen and former chair of the European Respiratory Society's Environment and Health Committee, Dr. Anderson has shaped research and policy on air pollution and respiratory health across Europe. Her work bridges science and advocacy, focusing on vulnerable populations and chronic diseases like cancer. A trusted advisor to the World Health Organization and other global bodies, she brings a powerful voice for evidence-based climate and health action. We're honored to have her with us today. Both presentations have been pre-recorded, but there will be an opportunity to answer your questions during the live panel discussion, so feel free to submit them during the presentations. We look forward to an active conversation today and welcome your engagement throughout the program.
Hello, everybody. My name is Joan Schiller. I'm a lung cancer medical oncologist who is currently serving as chair of the steering committee for the Oncology Advocates United for Climate and Health International. And I would like to thank you very much, thank NCCN very much for inviting me to talk about the connection between climate change and cancer. So let's briefly define climate change and how it happens. So I think what many of us don't know is that most of the solar energy from the sun gets reflected back into space. But some of it is trapped in the atmosphere by greenhouse gases and re-radiated down to Earth. And that's a good thing because otherwise we would have a frozen planet. But what causes the climate to change? Well, basically it's too many or too much greenhouse gases. It says that if there's a blanket around the Earth, which has just gotten thicker, trapping all the heat that would normally have gotten reflected back out to space, back down to Earth, heating the planet up. And where are these greenhouse gases coming from? Well, primarily from the burning of fossil fuels. And we really do have a problem here. The UN Secretary General, Antonio Guterres, said that by allowing the climate crisis to spin out of control, we have opened the gates of hell. And why would he say that? Well, first, let's think of what does climate change actually do? It increases, obviously, the global temperature, causes extreme weather disasters, precipitation extremes, droughts and floods, sea level rise, and changes in land use and growing seasons. And these have effects on how we live. It causes extreme heat, air and water pollution, reduced food and water quality, changes in infectious diseases and vector transmissions, and increasing allergens and allergies. And these have impacts on health. They cause health-related illnesses, cardiovascular diseases, strokes, mental and neurological disorders, other vector and waterborne diseases as the geography of these vectors expands, and respiratory diseases and asthma. But what wasn't listed on here, and what I think most people don't know, is that climate change is also impacting cancer incidence, treatment, and outcomes. Now, I'm going to use the word air pollution similar to climate change, even though they're not technically the same thing, but they're pretty much two sides of the same coin. They are both caused by the burning of fossil fuels. Air pollution is actually classified as a carcinogen by the IARC. And as I will show you, it's arguably the second most common cause of lung cancer, even in people who have never smoked. And how does it do this? Well, air pollution contains a very small bits of particulate matter, or PM. And you can see here how small it is compared to a human hair. And it comes from the burning of fossil fuels. PM 2.5 is small enough that it can get into our bronchial epithelium and alveoli, where it can get into the circulation. And once there, it causes oxidative stress and systemic inflammation, which can have significant health effects, such as endothelial cell dysfunction, impaired respiratory function, such as bronchitis, COPD, cardiovascular inflammation, cardiovascular disease, and cancer. And how does it do it? Well, PM 2.5 comes from the burning of fossil fuels. Once it gets into our lungs, it causes oxidative stress and low-grade inflammation, which causes all sorts of molecular changes in our DNA, such as DNA adducts, gene mutation, changes in non-coding RNA, and so forth. Now, it may take time for these changes to accumulate, but accumulate they do, and eventually turn into a cancer cell. In fact, it is estimated that air pollution caused over 265,000 deaths due to lung cancer globally. That's 14% of all lung cancer deaths. And let me show you some data to support this. This is one of several epidemiological studies involved. This one involves over 635,000 individuals from 1987 to 2014. And the investigators found that if individuals lived in areas with high air pollution, they were at an increased risk of dying from lung cancer. Here, the hazard ratio was 1.13, which means that these individuals had a 13% higher risk of dying from lung cancer as their air became more and more polluted. But of note, they also had a subset of over 340,000 people who had never smoked and found that they too had an increased risk of developing lung cancer, even after adjusting for all sorts of variables. There, the hazard ratio is 1.73, a 73% higher risk of dying from lung cancer. Now, this is a study from Taiwan comparing the northern section and the southern sections. This graph shows the amount of air pollution in southern Taiwan, which is in red, compared to northern Taiwan in green. And what this is graphing is visibility, which means as the amount of air pollution in the air went up, visibility decreases. And you can see that until about 1992, the visibility, presumably due to air pollution, in northern Taiwan was significantly worse than in southern Taiwan. But after 1992, things changed. The visibility in northern Taiwan improved, while the visibility in southern Taiwan got worse. What happened? Well, in northern Taiwan, where the city of Taipei is, they conducted a mass transit rail system and moved some factories outside the city. In contrast, the petrochemical industry started developing in southern Taiwan, and as it did, visibility got worse. Here you can see the incidence of lung adenocarcinoma in northern and southern Taiwan during that same period of time. Early on, when visibility was good in southern Taiwan, the incidence of lung cancer was low. However, as time went on and air pollution and visibility got worse in southern Taiwan, the incidence of lung cancer increased significantly, whereas in northern Taiwan, as the visibility and air pollution improved, the incidence of lung cancer leveled off. And I want to remind you that we are talking here about individuals who have never smoked. Another study, which looked at two large cohorts of never smokers who died of lung cancer. One group was from 1979 to 1983, and the second was from 1999 to 2000. And the third was the average of these two. I'm going to have you focus now on the last column, in which they made sure, as much as they could, they were comparing people of roughly the same age, sex, education level, etc. And they found there was an increase in lung mortality in never smokers, ranging from 15 to 21% higher, with increasing concentrations of PM2.5. Last study I'm going to show you here is another study that examined the association between long-term ambient PM2.5 concentrations and lung cancer mortality in never smokers. Here they found that each 10 microgram per meter cubed increase in PM2.5 concentrations was associated with a 15 to 27% increase in lung cancer mortality. Now, another way climate change affects cancer care is indirectly, such as through disruption of supply chains. In 2018, Hurricane Maria struck Puerto Rico and had a national effect on our healthcare system because the hurricane closed a factory that was responsible for the bulk of IV bags for the United States, resulting in shortages of IV fluids. And this happened again several years ago when one of the hurricanes hit Florida and North and South Carolina. And again, we had a problem with having enough IV supplies. Now, like we said, the most common source of air pollution comes from humans burning fossil fuels. That represents between 80 to 85% of outdoor air pollution. But there are other sources of air pollution that are not directly related to burning fossil fuels for energy, and these include wildfires. As the climate warms, wildfires are becoming more and more common, are burning more intensely and lasting longer due to the increasing heat and droughts. But just because we are not directly threatened by wildfires doesn't mean we're not affected by them. Smoke from these fires can blow east. This was a photo taken in New York in the summer of 2021. And does exposure to wildfire smoke cause lung cancer? Well, this is under active investigation right now. But in Canada, these investigators compared people who had lived close to wildfires and compared them to those who had not. And they found that there was a 4 to 9% higher incidence of lung cancer in people exposed to within 20 or 50 kilometers in the past 10 years. And there was a 10% higher risk of developing brain cancer. Another recent study found that PM 2.5 from wildfires is 10 times more harmful than PM 2.5 from other sources because it contains other types of pollutants, such as burning batteries or burning rubber, for example. What is the impact of wildfires on cancer care? This is a survey of radiation oncology clinics in California between 2017 and 2022. 61% of respondents reported being affected by a wildfire, such as clinic closures, staffing closures, shortages, transferring patients, canceling or rescheduling treatments, and having to evacuate. But only 40% reported their workplace had a wildfire emergency preparedness plan. And what about patients actually getting radiation treatments when a wildfire occurs in their area? Well, this study by Katy Winckworth and colleagues found that patients with locally advanced non-small cell lung cancer who were exposed to wildfire smoke within 12 weeks of the start of radiation therapy had a worse survival than those who were not exposed to wildfire smoke, with a statistically significant hazard ratio of 1.03. This is yet another study looking at patients with lung cancer who recently had an operation for their lung cancer and were exposed post-op to wildfire smoke. They found that being exposed to wildfire smoke while recovering from lung cancer surgery was associated with a worse survival than people who were recovering from surgery but had not been exposed to wildfire smoke. In fact, if they were exposed from 0 to 3 months post-op, the hazard ratio was 1.43, a 43% higher chance of dying. Other sources of air pollution that are not directly related to burning fossil fuels for energy, but are also important, are wood burning, such as wood burning stoves or fireplaces or outdoor fireplaces. Now, this is a study called the SISTER study. It was designed to evaluate environmental risk factors for breast cancer. So to participate in this study, you were not supposed to have cancer, but you were supposed to have a sister that had breast cancer. And over 50,000 women were involved. Breast cancer is developed in these women with a hazard ratio for developing invasive breast cancer as 1.13. Again, meaning that women who were exposed to wood-burning stoves or fireplaces had a 13% increased risk of developing breast cancer. And the hazard ratio for developing invasive breast cancer was 1.13 as well. But as part of the sister study, they also looked at the development of other cancers. Here, the risk of developing lung cancer was about 40% higher if the women used a wood-burning stove or fireplace, and if they were never smokers and had used wood-burning stoves or fireplaces for more than 30 days per year, it was doubly high. And this, again, even in never smokers. And last source of air pollution I'm going to talk about is methane. And which, as we all know, primarily comes from our gas stoves. But it turns out, even though people call them natural gas stoves, they're not really natural gas, because gas stoves, what they do is they burn methane. And methane is a greenhouse gas, and it is a greenhouse gas more potent than carbon dioxide. We always think of carbon dioxide as being the principal culprit when it comes to greenhouse gases, and that's because the majority of these greenhouse gases are carbon dioxide, about 80%, and carbon dioxide lasts a long, long time in the atmosphere. Having said that, however, methane is considerably more potent. Compared to CO2 at 20 years, it is 84 times as potent. And we burn methane, and when it leaks, it results in a variety of noxious compounds. And as I said, it leaks, and it comes not only from natural gas stoves, but also from leaking pipelines. So this is an image of an unlit flare pumping pollution into the air. And this picture was taken at the same time with an optical gas imaging camera. And you can see how much methane was being released into the air. And even when you're not burning your gas stove, there's still a problem, because 70% of all methane emissions come from leaks when the stove is not in use. Household air pollution results in about 4 million deaths each year. 270,000 of these were due to lung cancer. What are some of the effects of air pollution and climate change on cancer? Well, indirect effects are certainly there. Severe weather events, for example, will limit access to cancer care by delaying screening, treatment, or delays in research. And heat also is a major health problem with climate change. Our vulnerable patients can get dehydrated quickly. In addition, some of our drugs cause diarrhea, resulting in more issues with dehydration. Some of our drugs cause sun sensitivity, and some can be degraded or damaged by the heat. And heat can impact how we metabolize many of our drugs, such as by causing diarrhea and putting vulnerable patients at risk for dehydration. So let's move on now to weather and natural disasters. The effect of natural disasters on cancer care is both obvious and hidden, I think. Clearly, natural disasters can result in infrastructure damage. Roofs get blown off, windows get blown in, etc. It can also result in loss of power, water, and electricity, treatment delays, as we said. Something we may not think about, and that is patients who are escaping these natural disasters may not have their medications or pain meds, IVs, oxygen. There's transportation issues with these natural disasters, both in terms of getting patient to their healthcare facility, but also getting their healthcare providers to that facility. Disruption in communication has been a big problem. How do different floors and hospitals talk to each other if the electricity is out and the telephone is out? How to manage your workforce? Who is coming to the hospital? Who is not? Who's taking the care of the kids, the people who are coming to the hospital? Another problem was loss of medical records and tissue samples. This was a big deal when a hurricane, not sure which one it was, hit Houston a number of years ago and flooded out Baylor's basement, where they were keeping their medical records and very important tissue samples, which could not be salvaged. And of course, we have to worry about patient and staff evacuation. Where are they going to go? How are they going to get there? What will they find when they do get there? Something we don't always think about, these extreme weather events can result in accidental releases of toxic carcinogen. Hurricane Harvey, for example, when it hit Houston, more than 100 toxic releases from 40 sites happened, with tons of hazardous chemical waste also released. And these extreme weather events can also impact supply chains thousands of miles away. In 2018, Hurricane Maria struck Puerto Rico and had a national effect on our healthcare system because the hurricane closed a factory that was responsible for the bulk of IV bags in the United States, resulting in national shortages of IV fluids. How does a hurricane actually affect cancer patients? Well, this is a study which looked at over 1,900 patients who were undergoing definitive thoracic radiation therapy for their stage 3 lung cancer when hurricanes hit their neighborhood. And they compared their data with close to 130,000 patients also undergoing curative radiation therapy, but in non-hurricane related weather. And what you can see here is that it took patients in the hurricane hit areas much longer to complete their radiation treatment, not a surprise. And that was due to disruption of service, inability to get to the treatment facilities, blackouts, etc. But look at the difference in outcome. For those disasters lasting 27 or more days, it's not just treatment delays for advanced disease patients. This is a study which looked at over 1,900 patients who were undergoing definitive thoracic radiation therapy for stage 3 lung cancer when hurricanes hit their neighborhoods, and compared their outcomes to about 129,000 patients who were also undergoing thoracic radiation, but non-hurricane weather. And as you could expect, it took patients in the hurricane hit areas much longer to complete their radiation therapy than those who were not in those types of areas. And look at the difference in outcome. 27% lower survival in those patients who had very long disaster-related areas. And now, the other thing we must not forget is that the poor and underserved are affected disproportionately by climate change. And this is just one study to illustrate that. This is a study of the different wards or neighborhoods in Washington, D.C. It shows the percentage of African Americans by wards, and the neighborhoods with the highest, here you can see the PM 2.5 attributable excess mortality rates. And when you look at these two, you can see that the higher the patient population of African Americans, the higher the PM excess mortality rates was. And part of that, at least, is due to those poorer areas. They had 10% lower education and employment rates, 10% more residents living in poverty, 61,000 lower median household incomes, and about 10 fewer years of life expectancy. Now we are looking at the lung cancer excess mortality rates, and you can see how directly they overlap with those in the poor and underserved areas. So what I wanted to make sure that everyone saw that the different types of air pollution all illustrate that direct or indirect burning of fossil fuels are man-made and impact the care, incidence, and outcomes of cancer patients. So as respected, trusted messengers, physicians and other healthcare providers play a unique role in addressing climate change. And in my opinion, we have a moral obligation to speak out and take action to mitigate the impact of climate change on our cancer outcomes. So with that, I thank you because there is no plan B. Thank you.
So my name is Zorana Jovanovic-Andersen. I'm professor in environmental epidemiology at the Department of Public Health at the University of Copenhagen. And I'm also very active with European Respiratory Society, where I have been acting chair of the Environment and Health Committee for 4 years. And right now I'm a chair-elect of the ERS Advocacy Committee for the coming term starting in 26. So thank you for inviting me to speak today. It's my pleasure to talk about environmental exposures, climate change, and cancer, with a policy imperative angle. So in this talk, I will take a little step back and introduce air pollution globally. What are the levels, sources, and where we are right now with the knowledge on air pollution health effects overall, and then zoom in on air pollution and cancer link, overview of what we know, where we are. Then I'll make the link between climate change and air pollution. Why are these two inseparable issues, and how climate change will change air pollution exposure and affect cancer risk. Then I'll switch a little bit to this policy imperative, talk about some needs on how we best translate evidence to policymakers and how do we create room for action, and conclude a little bit on the overall talk and where we are evidence-wise on air pollution, cancer, climate change, and cancer with a call for action. So when we talk about air pollution, I will in this talk focus primarily on PM2.5, which is the name for the small particles with a particulate matter with diameter less than 2.5. And without broad introduction, I would just like to mention that this is the pollutant that has been most consistently linked to health, for which we have a number of reasonable monitoring around the world or modeling that we know very well the levels and understand very well health effects. And so mostly we talk about PM2.5 when we talk about health effects, and for this presentation, I'll keep it here. So when we look at the air pollution levels across the globe, and this slide has been borrowed from the State of Global Air report that just came out at the latest 25 report, which gives us this overview of air pollution level in 23. We see that there are these very large disparities around the world, with blue being the low levels and up to brown, reddish to where the highest level of PM are. And we see these highest levels in Southeast Asia, Eastern Europe, Northern Africa, Latin America, and so on. What is the key thing to mention that WHO developed and has been issuing their global air quality guidelines, and the latest one for 2021 has made a review of health effects of air pollution, and according to that review, set a guideline for how low air pollution should be in order to prevent health effects. This is the guideline for action, guideline for governments around the world to set the standards for air pollution, legally binding standards. And this report tells us that for PM2.5, the guideline is 5. That is really everything darkish blue. So what really came as a alarming message from this latest guideline is that everybody, literally around the world, 99% of world population lives in areas that have PM2.5 concentration above 5 at various levels, but pretty much everybody around the world is exposed to air pollution levels that are dangerous for their health. And that is one of the alarming messages, and maybe one of the main reasons for call for action. We see also very large disparity across the world. We have seen this in the previous graph, but here we can see that this is really up to several fold differences in the areas where air pollution is lowest. This would be Northern US, Western Europe, Northern Europe especially, and so on. And the Southeast Asia, where experiences the highest levels of air pollution, is countries as India and China, which have made some progress, and so on. So overall, this black line and we see some reduction and some good stories, especially reductions in this part of the world with lowest air pollution, but still in many parts of the world, we still have unacceptably high levels of air pollution, and these high disparities are also something that needs to understand the background call for action. There are many sources of air pollution. For PM2.5, there are a number of sources. This also reflects complexity of the issues, and we really need to work across different sectors to understand exposure to air pollution and to regulate air pollution. What I really want to mention related to this call, that fossil fuel combustion for transport, for transportation by cars, trucks, and so on, for energy production, especially old coal-burning power plants are part of the problem. Old industry, as well as a very big part of still exposure to air pollution, comes from residential use of fossil fuels such as coal, wood, for heating and for cooking. This is still a major source around the world. And so still to say that fossil fuel combustion presents major source of air pollution and also is a climate change driver. These are especially the same greenhouse gases that are primary causes of climate change. But there are a number of other, and we'll talk more about air pollution sources change in relation to climate change. Air pollution health burden is also well understood now. We have huge amount of evidence on the studies looking both at mortality and morbidity from air pollution. And again, this is a slide from the latest State of Global Air report that maps number of deaths due to air pollution, which is the metric we use to describe this kind of background burden, how many people die prematurely due to a health risk factor. And here we see again that the latest report outlines that there are 7.9 million deaths attributed to air pollution in 2023. This is 1 in 8 deaths worldwide is due to air pollution. Of these, 4.9 million come from outdoor air pollution, PM2.5 exposure, and 2.8 from indoor household air pollution, but many of these are due to cooking indoors and so on, sources that also contribute to outdoor air pollution, and a minor part from ozone, which is increasing due to climate change. So this is the division of those number of deaths. And if you look globally, again, we see large disparities with highest number of deaths. These are standardized deaths per 100,000, so we can make comparisons. And we see some hotspots again in Southeast Asia, where we also see the highest number levels of air pollution. In Northern Africa, here's also we have some dust exposure, and Eastern Europe also has still high air pollution problems and high burden. Majority of deaths due to air pollution, 86%, come from non-communicable diseases. And here we see that established causes of deaths due to air pollution represent ischemic heart disease, stroke, chronic obstructive pulmonary disease, dementia is one of the newest diseases added, lower respiratory infections, lung cancer, and type 2 diabetes. And these are quite significant portions of these diseases, mortality that is due to air pollution. And here we see that for lung cancer, actually globally, 17% of lung cancer is attributed to air pollution. So this is a large preventable fraction if we do something about air pollution. In another way, we can also say here, if we look at lung cancer compared to other diseases, most of lung cancer deaths come from ambient air pollution and from ozone. And 1 out of 6 lung cancer deaths globally is due to air pollution when we zoom in into cancer. Air pollution, because of this link to all major non-communicable diseases and because everybody is exposed, ranks now as the second biggest risk factor for mortality and morbidity globally, just after high blood pressure. So this is really also alarming call for action that air pollution accounts now for more deaths than tobacco smoking and other well-known risk factors for health. Air pollution and cancer story is also well established. Already in 2013, International Agency for Research on Cancer has classified outdoor air pollution as carcinogenic to humans with its highest level of evidence. This is carcinogenic of group 1. based on mechanistic understanding of air pollution, toxicological properties, and how they contribute to development of cancer, and with sufficient evidence from epidemiological studies that exposure to outer air pollution causes lung cancer. This is again of highest evidence. So at this time, already in 2013, we had enough evidence enough studies on air pollution linked with lung cancer. Mechanistically, we also understand quite well that air pollution, and here primarily PM2.5, contains a number of chemicals from different sources, such as metals and so on, that are carcinogenic, but that also other pollutants in the air, such as benzene, polycyclic aromatic hydrocarbons, or PHs, they all can, upon inhalation, penetrate to our lung, and further through bloodstream to most of our organs, and here cause inflammation and oxidative stress. And all of these can lead to mutations and disruption of normal cell repair mechanisms, as well as give direct DNA damage, and by this increasing risk of development of cancer. EARC has also looked at a different number of different evaluations on diesel and gasoline engine exhaust and to bitumens and so on, and also evaluated them as carcinogenic. So air pollution has been evaluated in a number of reports as carcinogenic, and this is now well established. When we look at lung cancer, epidemiological literature of air pollution lung cancer is very large and exhaustive, and I just pointed out here reference to a number of key papers. First two papers by Hamra from 2014 and 2015 summarize in a meta-analysis literature on PM2.5 in lung cancer incidence and NO2, nitrogen dioxide, which is mainly traffic-related air pollutant, proxy of traffic pollution. And I refer also to two large studies from 2013 and 2021 from large European studies, ESCAPE and labs, that have put together data from a number of large European cohorts, and also clearly showed link of air pollution and lung cancer incidence. Air pollution has also been shown to affect lung cancer patients after diagnosis of lung cancer in form and that has adverse effects on the lung cancer after diagnosis, shortening the life, resulting in shortened survival after lung cancer. That is also described in one of the papers from 2016, as well as lung cancer mortality has been studied as an outcome in a number of papers. And I also refer to this latest summary of evidence of PM2.5 and mortality studies, not just lung cancer, but a number of others. But here also, it's a latest summary of studies also that looked separately at lung cancer mortality, and there's a clear link that air pollution increases both risk of developing lung cancer as well as dying from lung cancer. And we see more and more studies on worsening survival after cancer, showing that air pollution or cleaner air would benefit both in reducing risk of cancer, preventing new cases, but also improving prognosis and life of patients after cancer diagnosis. Air pollution is also linked to cancers other than lung, as I mentioned, by EARC establishing that air pollution is carcinogenic. That means that particles reaching all other organs, that the same mechanisms would apply, and there is plausible that air pollution can cause cancers beyond cancer. And now we have increasing number of research studies and research projects looking especially in cancers other than lung. Here I briefly just summarized some areas. Now there has been perhaps small studies on air pollution and breast cancer. And I just mentioned again few studies here, few reviews that show this association, and I think there is likely that soon we'll have also established association with breast cancer. On gastrointestinal cancers, now we have enough studies to establish link with liver cancer, and more studies with colorectal cancer, and not so many yet on esophageal, gastric, and pancreatic. There's a nice review that I refer here from Pritchett in EHP from 22. Their urinary tract cancer has also been looked at, and some studies suggest evidence with bladder cancer, but not with kidney or urinary tract cancer. And also a number of studies have looked at brain tumors or tumors of central nervous system. And also there's increasing study of likely association, although this is a rare cancer, so the studies are a little bit less powered for this association. No association was found with blood cancers, leukemia in the studies. And here, in the interest of time, I do not cover childhood cancers, but this has also have been matter of study. A number of studies have pointed out to some possible link between our childhood cancers and so air pollution and childhood cancers in blood. But here also I refer to this nice recent review on air pollution impact on cancer incidence, cancer care, and cancer outcomes from BMJ that just came out, if you're interested to read more about this topic. Just to remind that beyond cancer, air pollution causes many other diseases, and this is okay, just a brief review that we know now of the link of infectious and chronic respiratory diseases in the lung. We know also very well now that air pollution causes all major ischemic heart diseases, as well as high blood pressure, heart failure, and metabolic diseases, type 2 diabetes, via systematic inflammation. And some of the latest research now in the brain has established a link with stroke, but as well as with neurodegenerative diseases such as dementia, Alzheimer's, and likely also mental health. There are a lot of studies now on depression, anxiety, and other mental outcomes. Also, it's very important to mention that air pollution it affects pregnancy outcomes. Exposure via pregnancy on unborn children is very concerning. And there's established link with low birth weight and so on. So just to mention that air pollution is linked to a variety of diseases, and we know very well, just as with cancer, how these mechanisms work, and there's really abundant epidemiological evidence. So related to air pollution, I'll mention that climate change, driven by a lot of the fossil fuel pollutants or greenhouse emission factors that we see in this unprecedented global warming as a direct consequence of climate change. And I think this has also been covered in a talk before me. I just want to mention that we are very well aware that climate change impacts health directly, although this has been maybe coming too late on climate change agenda, and COP28 was the first time mentioned health, and now of course we are working on much more to understand impacts of climate change directly on human health. But we know that related to health, to lung health and lung cancer, there are this number of pathways with which climate change impacts lung cancer. We have been working in European Respiratory Society, and I'll just switch to next slide, to recognizing climate change as a great threat to respiratory health, including lung cancer. And I just point out to these two statements where we wrote an evidence review and stated a European Respiratory Society position statement as a medical association, really recognizing the climate change crisis is a health crisis and great concern for respiratory health, and we made this clinical review. Part of that review is this slide that here we maybe focus more on chronic respiratory diseases, but also relevant for cancer. So of course, there's a direct impact of heat waves, and related to cancer, increased exposure to sunlight, ultraviolet radiation are directly relevant for skin cancer, for melanoma, and we will see increase in these due to climate change. There are also the indirect pathways due to worsening of air quality. Climate change is contributing to more adverse weather and increased frequency of severe weather and events such as droughts and heat waves and so on. And this will directly change air quality, composition, and sources, as we are going to see, and we're already seeing many more wildfires that really pose great risk and great exposure to air pollution. We have seen many of them throughout Northwest Canada, in Southeastern Europe, and projections are really grave that we will see many more of these, and many will affect large urban areas. And in very large, intense exposures to air pollution to those affected close by, but also a lot of these particles travel far away and affect many people along the way. Due to climate warming and higher sun exposure in many places, we'll see higher ozone levels in the cities around the world, and this will also impact health and risk on cancer indirectly. And we'll also see more dust and sandstorms due to more droughts, more sand and more storm events. So these kind of exposures to large particles will also change the air quality composition and result in greater exposure to these types of air pollution events. This will all have impact on cancer that we outlined that are already linked to air pollution exposures, and likely in synergy or interaction with some other factors. I just here want to mention a project Exhaustion that a few years ago, large EU project that looked at interaction between heat exposure and air pollution exposure, and found that across European cities, from north to south, we see larger effects of air pollution on respiratory deaths in people that have chronic respiratory diseases. They're more likely to die on the days of high air pollution and very warm weather. Both high heat episodes lead to increased risk of death in respiratory patients as well as air pollution. But when you have both of these events together, and we are seeing many more heat waves and higher temperatures across the globe, a mix of these with high levels of air pollution in the cities will really be even more dangerous. And this will also affect cancer patients. So this is just one type of those interactions that climate change will pose, and presents even more argument to clean up in the air pollution and provide cleaner air. So policy-wise, where do we go with all this knowledge? I just want to point out to some important statements in Europe, in EU. A few years ago, EU has started BECA, or Europe Fighting Cancer Plan. And this was very important because this was a realization that still cancer is one of the main causes of death in Europe, and there hasn't been such good successes in prevention of these deaths as maybe for cardiovascular mortality and so on. And the very important aspect of this is recognizes that exposure to environmental exposures is probably has been understudied and understood and underestimated, and probably that a lot of the deaths and a lot of the cases of cancer are still due to environmental exposures, but it's just not explained by genetic and lifestyle factors, and that we need more research and more understanding and recognition of this, and this will lead likely to more call for environmental regulation to prevent cancer. European has this large, ambitious Green Deal political program to reduce air pollution and climate forcers in EU. So this recognition and link between environment and cancer was a very strong signal that we really need to do more about this, both regulation-wise, but also research-wise. European Environmental Agency has also in this period published a very important report on cancer, realizing that there is a lot of environment that explains cancer, also posing that maybe 10% of all cancer cases in Europe are likely to pollution, and even more to broader environmental factors. So this was a strong signal from policymaking on the cancer and environment link that calls for more action. How do we translate research to more policy? I just want to point out to some of the mechanisms that European Respiratory Society has used. We have been lobbying, so to say, for clean air, for cleaner environment, climate action mitigation, through editorials like as this one. This was editorial calling for alignment of air quality standards when EU revised their air quality directive. This is a law setting standards for air pollution in EU, which happened during the last 4 or 5 years in Europe. We got very actively engaged, and we published this statement as editorial calling clean air for healthy lungs, urgent call to action, and we outlined again why air pollution is important for lung health, and calling for clear, most ambitious standards in EU to provide better lung health. We have also made alliances with other associations, with European Cancer Organization, also with Cardiovascular, World Heart, and so on, and made this kind of joint health voice for call for action on air pollution to have a stronger voice together. Again, this was published as an editorial, and we have used this in a lot of our appearances with EU and other meetings globally, calling for action. We are also proactively using research results and to serve them to politicians. This is just an example of a webinar on the Health Effects Institute, American funding agency, and European Respiratory Society, where we invited some politicians from EU organized a webinar where we presented the results of a very important large European project, from which also important studies on lung cancer air pollution links came out, to serve the results to politicians directly and engage them in discussions on how these results can be translated to actions. So it's important to present results not just to academic conferences, but also to go engage policymakers directly in some of our dissemination of research results activities. And it's very important. Another way to better action is to share our results with mainstream media. There is still a lot of misinformation or lack of information and understanding of how dangerous air pollution is among public, among patients, even among clinicians. So having these results communicated through mainstream media, through main outlets, newspapers, news, podcasts, and social media is extremely important to still keep educating the public. Even if our politicians know about these links, but voters are not going to support and call for these actions because they're concerned about economy or the number of misinformation about these issues, then they're not going to go out with these policies. So public pressure on politicians is important, and the way forward is information. So to summarize, how do we efficiently transfer all this knowledge into policy? We have to directly translate our research results to policy makers and engage them both in our research, even from start of our research and designing research, but especially in bringing the results to them in the language that they understand and relevant for the policies. And building a lot of alliances and partnerships with with medical associations, with patient organizations, as well as environmental non-governmental organizations that have understanding and contacts with politicians and that know political insights, that know which policies are being considered, so that we also know how to talk to which policies, understand the timing and whom to talk, and exactly when is the good timing to serve the knowledge. Indirect impact of policymakers is extremely important by building awareness among voters. Here we have to empower public on environmental issues, on health effects, links, and so on. And we need to educate as well as healthcare professionals and patients. This is important as they're very important voters. They can really spread the knowledge. They're very respected members of society that can educate better about effects of air pollution than us researchers, but also because they can implement this knowledge in their clinic and directly help patients, for example, in lung cancer, to understand links with air pollution, so they can do something by themselves, maybe to not use their wood burner anymore and so on. If they understand these links, they can actually maybe help improve their health. So to conclude, air pollution cancer link is very well understood. We know we have many studies, excellent understanding of the carcinogenic effects of air pollution, and enough evidence on the matter that our call for action is justified. We know very well that the reduction of air pollution is a major public health issue, and reducing air pollution would prevent substantial number of new cases of lung and other cancer types, as well as other non-communicable diseases. Cleaner air would improve life of lung cancer and likely other cancer patients. There's clear indirect benefit for health. By reducing air pollution, we would mitigate effects of climate change, slow it down, and mitigate some of those indirect impacts on our health and our planet. And action is needed across all sectors. Fossil fuel phase out should be at the core of these actions. But we need to tackle and do action across traffic, residential heating and cooking area, energy production, industry, as well as agriculture to accomplish reductions in air pollution. And with this, I would like to thank you for your attention. I leave my email here for additional questions, and I'm happy to as well answer questions in the panel discussion. Thank you.
Hello, everyone. Thank you for joining us for our webinar on the impact of climate change on cancer. We're pleased that you can join us for this panel session. As Katy mentioned earlier in the program, my name is Gary Waymiller. I'm the Executive Vice President, Chief Operating Officer of NCCN, and I'm happy to be hosting this panel and being the moderator. My panelists are joining me now. I just wanted to mention that if you do have questions, You can submit them to the Q&A button you see at the bottom of your screen, and we'll try our best to get to as many audience questions as we can. So my panelists have joined. You already know Dr. Schiller and Dr. Anderson, as they've just presented. And I'd like to turn to Ms. Oti and ask her to introduce herself and just give a brief statement on why you feel that you are on this panel.
All right. Thank you very much, Gary. Hello, everyone. I am Naomi Ohini-Oti from Ghana, a passionate oncology nurse specialist from Ghana. And I am currently an adjunct faculty for the Ghana College of Nurses and Midwives. I'm also the head of nursing for the National Radiotherapy, Oncology and Nuclear Medicine Center. I'm also privileged to be the chair of the Special Interest Group for Aortic for Oncology Nursing, African Organization for Research and Training in Cancer Care, where I work with colleagues across Africa to strengthen cancer nursing education, leadership, and advocacy. And my professional interests include cancer policy leadership, survivorship care, and mentoring the next generation of nurse leaders. And I'm really looking forward to learning and sharing ideas in this climate change with all of you today. Thank you.
Thank you, Naomi.
For having me.
Thank you. And now turning to our next panelist, Dr. Nimrod, could you please introduce yourself and why you're here on the panel?
Okay, good morning. My name is Dr. Marissa Nimrod. I am coming from the beautiful Caribbean. I live in Trinidad and Tobago, and I am the CEO for the Caribbean Association for Oncology and Hematology. I am a physician by training with a master's in public health and global health, and completed a summer fellowship in cancer prevention and control. I represent a multidisciplinary team of physicians, oncologists. It's just been amazing to unite the Caribbean in terms of cancer prevention and control. We live in an area that's definitely impacted by climate change with respect to the islands, and quite happy to discuss what our course has been and the opportunity to be part of this global panel. So thank you.
Thank you, Dr. Nimrod. Turning to our panelists, our first question is for Dr. Schiller. Dr. Schiller, in your presentation, if you could just expand and elaborate on the most urgent climate-related risks to cancer patients and healthcare systems.
Sure. Excuse me. And again, sorry. Thank you again for having me. Frankly, I would say the most urgent risk is the fact that people, regular old people, don't realize there is a risk, a climate-related risk to cancer treatment, cancer incidence, and cancer outcomes. And until we get that word out, I think once we get that word out and that people understand that, I think there will be more of a public outcry about we have to do something about this.
Thank you. Dr. Anderson, in your presentation, you emphasize policy imperatives that are policy imperatives. What are the most critical gaps in current climate health policy frameworks when it comes to cancer prevention and care?
Thank you, Gary, and thanks again for having me in this exciting webinar and panel discussion. So some of the key elements of my talk and Joan's talk was this very strong evidence we have and understand how aspects of climate change and hereby also air pollution affect cancer. With lung cancer, we knew already since 2013 that air pollution is carcinogenic. With climate change impacts and changing composition of air pollution, we know that this is going to be even more acute with these changes in air pollution. Policy, I will kind of say same thing as Joan. We have enough evidence, but policy has not been listening in a way. Some of the key barriers to this, one important for me, that air pollution and climate change agendas and research communities and perhaps policy making, at least in EU, have been working in their own silos. And this is unfortunate, as we've seen, fossil fuels are the main sources of most harmful air pollution, from residential heating, from energy production, from industry, from traffic, but they're also main drivers of climate change. So the sources and the solutions are the same. Health impacts on cancer are very interconnected and related. So we have to break these silos and really serve solutions for both agendas, that there's a huge benefits or co-benefits, or however you phrase it, for both agendas, and they will bring great benefits for health and prevention of new cancer cases, and so on. And another part is probably lack of information. I think policymakers, and when we talk to them, I think they know and understand the link, but if there's a lack of support among voters, if there's a lack of information among communities, public, and especially for us, something very in the heart of our work at European Respiratory Society is information to clinicians and patients. I think they understand, they see these links. So I think more information through medical communities, to patient communities, to public, and pressure on our politicians that this is really a necessity, planetary, but our own health necessity, public health necessity, I think are some of the important parameters to get more action going.
Thank you. This next question is for Dr. Nimrod. Dr. Nimrod, could you tell us what cancers are most prevalent in Trinidad and Tobago, and how have climate-related disruptions impacted diagnosis, treatment, and/or continuity of care?
Sure. So in Trinidad and Tobago, according to our cancer registry, for women, breast cancer is the most common cancer overall. This would be followed by uterine cancer, endometrial cancer, colorectal cancer, cervical cancer, and ovarian cancer. With respect to the men in our population, prostate cancer is still leading in men, followed by colorectal cancer, lung cancer, leukemia, and then pancreatic cancer. So the Ministry of Health has the same public summary that says that breast is still leading for women and prostate is still leading for men in Trinidad and Tobago. And these statistics can also be found with respect to GlobalCam, which is where our statistical data is actually published online. And you spoke about how climate change, climate-related disruptions can actually impact with respect to diagnosis, treatment, and continuity of care. So where we are situated in the Caribbean, as noted, I mean, we are at risk for having extreme weather events, right? So this can lead to, as was experienced just recently in Jamaica, more frequent and severe storms or hurricanes. We have flooding. Hurricane Melissa just impacted on Grenada, Category 5, and unfortunately left a lot of devastation going forward. We had one experience in Trinidad and Tobago a while ago where we also had a natural disaster that was proclaimed as a result of inclement weather, and this would affect the continuity of care for our patients, for example, in terms of access. So we're looking at possibly blocked roads, depending on, downing of trees, looking at flooding, power outages. So these definitely delay patients coming to get their regularly scheduled treatments. And as a result, depending on their medical facilities that are being affected, can compromise, for example, cold chain medications. And even if there are any changes with respect to electricity or power supply, it can affect the radiation or radiotherapy treatments that are planned. We've had incidents before that has been documented in the Lancet Countdown that was published recently by the University of the West Indies in collaboration with some other stakeholders that spoke to heat waves and power reliability in 2024, where we had surges, and this is in Trinidad and Tobago, where there was at least about a 77.7 heat wave average, with respect to the days during 2024, which resulted in the health services experiencing power cuts, right, during extremes of temperature. And then there would be dependence now when we actually have loss of electricity with respect to backup from generators that are going to be fueled by diesel, which now will be contributing from that to the hydrocarbon that's being released into the atmosphere. And we spoke about the air quality a little earlier. So that lack of electricity, because most of the services will be driven, would result in the need for some sort of arrangement with respect to patients and their treatments, which are normally from Monday to Fridays if it's radiation therapy, and making sure that we don't compromise the care experienced in terms of having curative intent and better outcomes for patients. And then finally, looking for also vector-borne diseases as a result of temperature changes, for example, dengue. It was noted that during this period where we have normally during our rainy season, we have two seasons, dry season and rainy season, that when we have a surge with respect to, for example, dengue, causes a strain on the healthcare system already, which can compromise just routine non-communicable diseases or cancer visits, according to that same article with respect to the Lancet Countdown. So how do we mitigate for those things? Well, in clinics, we would try to, if we know that something is coming, we would actually arrange with the patients in terms of the scheduling. So we try not to miss any of the treatments that have been previously booked. If it's possible and they're equivalent, if there are medications, for example, if it's going to be IV 5-fluorouracil and there's equivalent, we have that opportunity to probably switch them to oral medication like capecitabine, depending on the treatment, and then making sure that we have that power supply or backup so that we have continuity of services. So even if we have, temperature changes or extreme weather events, we have a contingency plan in place so that we ensure that patients still are able to have their cancer management and to have their regular follow-ups, not just treatment, but even surveillance or even imaging, so that we give them what is expected in terms of best practice.
Well, thank you, Dr. Nimrod. Our next question is for Naomi Oti. Naomi, in Ghana and across West Africa, what infrastructure or workforce challenges are affected by climate change in the oncology setting, and what sort of nursing-led adaptations to this have you seen work?
Right. Thank you very much. This is a very important question. To be honest, I say this subject is becoming more and more urgent every year. It's not so, we're seeing that climate change is already rubbing it against cancer care in the near future. So it's not so clear within policies, but it's something that is coming up. And I might say we're having some challenges, especially for some time now. We've been having heat waves, which is also affecting most of our treatment, electricity dependent. And having heat waves, we are having power cut off, almost similar to what Dr. Nimrod said, and also flooding. We are having flooding. When floods happen, automatic, when there's a downpour, automatically our lights are off. And it also affects the delivery of our treatment in terms of especially radiotherapy. And so it's something that has been a challenge. And some centers have tests, which means that you pay more money, you have to buy more gas to be able to fill for the genset to work. In areas that they don't have genset, that means treatment has been abrogated and then until the electricity come on before. So it has been a real challenge in terms of the heat waves that are coming and flooding. And just recently, I just heard we've been having lung cancer also been coming up by and by. Most of the time before they are seen, they might be diagnosed as TB, going through the whole system before coming. But Ghana is having this challenge of, say, air pollution and a whole lot of things in terms of water pollution. And we are foreseeing that in the near future, we're going to have a lot of some cancers, especially because of the pollution of our water and even our airspace. About last month, a paper came out that over 20,000 deaths are related to air pollution within the country, specifically for Ghana. And this is similar across Africa or West Africa. They're having, Nigeria is having, they have their machines, some are not working because of this on and off power fluctuation, so it's affecting the outcomes of this machine. So it has been really of a challenge. But some of the nurse-led programs have been trying to, especially we really saw this coming up during the COVID, where we had to reinvent and go to tele nursing, where we're trying to assess our patient virtually. And the training of oncology nurses have also helped in decentralization of some cancer services. And so some patients may be having some cancer services nearer to them, especially up to some district level. But others, we have to try to schedule call. We are able to access, because majority of Ghanaians now have phones where we were able to reach out to them so as to schedule their treatment. And in terms of vaccinations, now they have these cool containers where out of reach, where they don't have the power, they have central points where there are power, there are other generators able to power those ones. And then we get our community health nurses go in to do the vaccination and come. Ghana just recently launched the HPV vaccine for girls. And this is quite critical to be able to make sure that the cold chain is maintained. And this has been done by the innovation from nursing, trying to make sure that the vaccines get to the appropriate quarters and making sure that the cold chain is maintained. So those are some of the innovations in which our nurses are coming up. In terms of, I know that diagnostics and treatment capacity is also vulnerable, but we are rallying on, trying as much as possible, liaising, coordinating care, making sure that patients get what they need in terms of their pathology reports and the like. So these are some of the things. We try as much as possible to be able to do also follow-up, decentralized follow-up, if we know our colleagues are elsewhere and there are some oncology nurses at a particular place and they can have the capacity to be able to give a particular drug, we then refer so that they don't have to travel all the way to our centers, because we have two main public centers. There's one private, and affordability is an issue, out-of-pocket payment. There is insurance for our patient, but not all cancers are on the insurance. So most of the services are out-of-pocket payment. So we try to see how best, if in coming all the way, there is a way some services can be given in where our oncology nurses are, so as to reduce the cost of the patient, at the same time making sure that patient receive his or her treatment. These are some of the interventions. So tax sharing also has been, we have these oncology nurses who have been trained, they are postgraduate oncology nurses who are able to assess and make some interventions in collaboration with our oncologists, because they're postgraduate trained. So they're able to help deliver some of the cancer services, especially chemotherapy, at their various areas. Those are some of the interventions that we've been able to put in place. And with the challenges, I might say we're able to, we published some climate changes and how it affects cancer services in low middle income countries. Those are some of the publications that we have. But there have been some publications in a general setting in terms of its effect on health, but not really related to cancer. But this is coming up and by and I think our next publication we just finished our meeting, the nursing special interest group at AELTIC. And one of the things that we're going to look at to be able to do the scoping review of our of climate change, how it's affecting oncology services within Africa, and what are some of the mitigated areas that we can do, even as nurse leaders, how we'll be able to empower our nurses to be able to take up and support our patients. So those are some of the things that we're coming up to, and also speak up to advocate for climate resilient cancer services.
Thank you, Naomi.
Thank you.
Very informative. Thank you. Dr. Schiller, how can cancer advocates empower patient voices in regions hit hardest by climate change? And second part of that question is, how can we keep the impact of climate change on cancer care a top priority in discussions?
So in terms of how cancer advocates can empower patient voices, I think the biggest way probably is to get the word out, to educate your neighbors, talk about what is going on with the climate, talk to local officials, hospital administrators, policymakers. People need to be educated as to what's going on. And, I think people, the general public, when it thinks of climate change, it thinks of it as a social situation or a problem or a environmental problem or a political problem, but it doesn't, I don't think the general public realizes it's also a health crisis. And we need to make sure the public understands that, as does our hospital, like I said, our policymakers and hospital administrators. I think in terms of keeping the impact of climate change on cancer care a top priority, I think we're going to do that through professional society meetings. Things like ASCO, American Society of Clinical Oncology, ESMO, the European Society of Medical Oncology. And then there's meetings which specifically focus on climate change and health. One of those is COP. COP, I think, is going to be I forget where it's going to be in a couple months. But there's a conference called the ISLAC, International Association for the Study of Lung Cancer, has an annual conference, and we need to, at those types of conferences, make sure that everyone there realizes what is happening. And I think to date, they may not have realized that.
Are there any examples of successful collaborations between advocacy groups and climate justice movements?
Yes, I think so. I can only speak to the US here, but my group, the Oncology Advocates United for Climate and Health, we do belong to several larger organizations, such as the Medical Society Consortium for Climate and Health, MSCCH, and another one is the American Lung Association Healthy Air Partners. And both of these are umbrella organizations primarily for US health organizations. And what both of these organizations do is they use their combined voices to advocate for cleaner environment and clean air and clean energy. And they do that by writing letters to national governmental organizations such as the EPA, testifying at a lot of these open presentations that organizations like the EPA has. I mean, federal organizations are required to allow a patient voice, a patient input, and these organizations are the type that gets the word out, what is coming up and what you can do about it.
Well, thank you. I do love the acronym for your organization as well, OUCH, or ouch. That's quite fitting. Dr. Anderson, how do environmental exposures and climate stressors intersect with social determinants of health to deepen cancer disparities?
Very good point. Socioeconomic disparities kind of underline and cross very much with environmental exposures and climate change. We see this globally. The places where we have highest levels of air pollution are usually the ones in some of the poorest, lowest socioeconomic areas. We see that even here in Europe, we're considered rich continent that had accomplished a lot with environmental regulation. Within EU, we have very much inequalities in air pollution exposures between Eastern and Western Europe. So we see locally within cities, within countries, of course, you have disparities, and we generally see across countries that people of lower socioeconomic background live in areas closer to the sources, whether it's industry, whether it's power plants, whether it's busy roads, or are affected by energy poverty, which we frame in Europe, and they are unable to afford housing with central heating and use still fossil fuels. So the dirtiest, the cheapest fuels that leads to higher exposure of these groups to their own communities, to themselves, and so on. So it's kind of a problem that exacerbates itself, that these communities are more exposed, and these communities are also perhaps lack information. We said lack of information is one of the key aspects here, and maybe even lack of access to healthcare, and are compounded with other social factors. These communities often suffer from higher rates of obesity, smoking, physical inactivity, so on, related to their lifestyle and background. And then you have accumulation of these social environmental factors, and then you see higher prevalence of cancer and other non-communicable diseases. We see that clearly in Eastern Western Europe ratio, also across the globe. So clearly there are links, and a lot of these solutions have to take consideration that, for example, in Eastern Europe, a lot of the solution phasing out fossil fuels needs to be also supported by some subsidies by governments from the richer countries to the Eastern to provide some support for alternatives, whether it's home heating, whether it's shutdown of power plants, still depending on coal. We really need some strong economic support to those that don't have means, because that's often a barrier. So socioeconomic contexts are extremely important. And then now we see third layer with climate change. A lot of the areas, for example, again, I'm back in Europe where I come from, but Southeastern Europe, which is one of the poorest areas in Europe, has highest air pollution level. This is the area also that's hardest hit now with global heat warming. That's where we have most heat, where it's highest temperature, where we had most drought or flooding events, wildfires, and so on. So you really see this accumulation of number of adverse risk factors for cancer, for other health outcomes. So socioeconomic aspects is extremely important. That's usually the root of many other health-related issues and risk factors, but also related also to exposure to environmental factors, dependency on dirty old fuels because of the poverty. So all this has to be taken together in a context to provide quick solutions and financial support to those most in need.
Are there any other strategies that could be employed to help reduce these disparities?
Well, again, information is the key, even for the poorest communities. In Europe, we often, even in the latest revision of European air pollution law, just to give an example, where we insisted that everybody in Europe deserves the clean air, there has been proposed a delay in adoption of the newest law for the poorest countries, kind of as a sympathetic, step to allow them to lag 10, 20 years in improving air because of economic considerations. But from health community, we think this is unacceptable. We shouldn't allow anybody to suffer from the risks that we know are very high, related to high exposures to air pollution and climate factors because of economy. I mean, health should be priority. Health should be the main drivers of this policies, whether we call them environmental, economic, they're all interrelated. We should all stick to polluter pays principle in a lot of these policies, which now is we are paying in our health. There is a high cost to air pollution. I think we also need a little bit change in our perception and how we measure the cost of our health versus economic progress. That's often I use as a reason not to insist on more stringent environmental policies. So I think putting health in the middle of all of this and in all sectors, not just health sector, but environmental sector, agriculture, transport, industry. If we get the cost of each sector on health, I think then we can quickly see the shift in priorities.
So there's a question from the audience that sort of ties nicely into what you were talking about with air pollution, and that is, since electric cars have been used for the last few years, is there any evidence that it helps with air pollution leading to preventable cancer risk?
Thank you. This is an excellent question. So electrifying our car fleets is definitely part of solution. So we get less exhaust emissions, especially from all diesel cars to newer cars. However, so any reduction of air pollution will contribute to less cancer cases and other health outcomes. So that is implicit, although we don't have specific study to look just in electrification and cancer cases. I'm not aware of such a study. However, we should also be aware that electric cars still produce particles from brakes, and these are very important metals that are carcinogenic, from tire wear, from road asphalt wear. So just replacing all cars with electric car is not a solution. We also need to limit use of cars and make our cities more walkable and bikeable and get active travel more into cities. We're really good at that in Europe. We're really good at it in Copenhagen. If you come here and see people biking around and walking and using public transport, this is also a solution for physical inactivity, probably the best solution for physical inactivity. If you get that half hour moving, walking, biking to your work, you accomplish the physical activity goals. So we need to work towards cities where we have to look a little bit in our habits and reduce number of cars, not just electrify them. But electrification, contributing in less emissions from exhaust, is definitely part of solution, but not only solution. And we should be aware of increasing portion of non-exhaust air pollution particles once we reduce the exhaust particles. And a lot of these are carcinogenic metals. So and then I call for that study. We have not seen specific study just with electrification. We generally look at reduction of any air pollution source naturally would lead to less cancer cases. But in case here that a lot of these metals in brake wear, asphalt wear, tire wear are really problematic, especially for cancer. I'm not going to jump to conclusion, but perhaps call for more studies on this aspect.
Well, thank you for that. That's very helpful.
I was also going to add, I think one of the problems, so to speak, of climate change and cancer is that both of those are relatively slow processes. So if we make an intervention now, we're not going to see an impact on breast cancer or lung cancer, for example, for a number of years, simply because it takes so long for lung cancer to develop. And similarly, if we make, and similarly, climate change itself is a very, by human standards, is a relatively slow process. If we were to all of a sudden get rid of all fossil fuel driven cars and went to clean electric cars, for example, we're not going to see the impact of that for decades. It takes a long time, and I think people aren't used to that type of time frame.
That makes good sense, yeah. And understandably, the length of time that it takes is, it's taken us a long time to get here. It's going to take a long time to clean it up too at the same time, yeah. Naomi, question for you. What role do nurses and frontline providers play in helping patients navigate care during the climate emergencies, especially when transportation or communication systems fail?
Right. Thank you very much. That's for the question. I think during climate emergencies, nurses really become the steady hands that holds the system together. And when transportation fails, our phones are off. They are not working. Patients don't stop needing care. They still need care. So nurses find ways to bridge this gap. Like sometimes in Ghana and for that matter, West Africa, we usually see this play out often. During floods, for instance, we see our community nurses stepping in to trace patients, sometimes using local radio or chat network to pass messages when phones are down. In our center, usually we'll be using phones. We try to track. So if not to the patient, then the patient relative to find someone sometimes to reschedule. It's so difficult for them to even come when they are floods. Well, they need to really wait for the flood to pass before they come in. But that assurance, when such things happen, disaster, there are calls when the need, trying to trace and to reach out to patient. We try to check them out. So sometimes we check who has missed treatments, who is stranded, who help, and we help to reorganize their appointment when the roads are clear. It's not formalized emergency work, but it's compassion mixed with improvisation. We also keep basic services running. Some clinics may have something we call resilient kits, like insulated boxes, especially for our vaccines, so as to make sure that their cold chain is not broken. Sometimes when the lights are off, we usually will put the compounded chemos into those boxes to try to make sure that the cold chain is not broken for patients to take their chemos as whole as it should be. And usually the nursing team may move quickly to protect the cold chain, as I said, transfer supplies quickly once such things will happen. So in the heart of all, it's communication. And our nurses are usually the ones who are always when there are breaks in treatment. They are the ones who are really assuring the patient, explaining the delays, calming fears, and helping them plan safely. And also when we can't give full treatment, then guidance and presence matter. So to me, nurses are not just responders. They are like the coordinators. And they hold the line between the health system and the community when anything else Simon said. And I think that's where our strength truly shows. Thank you.
Thank you, Naomi. I have a question for Dr. Nimrod. Are there public health campaigns or educational efforts in the Caribbean that can link climate awareness with cancer prevention or early detection?
Yes. So the answer is absolutely. The Pan American Health Organization has been spearheading a few of the programs with respect to climate change and its impact via education. So looking at webinars. So there was actually a webinar that was hosted online on the PAHO website, which addresses putting people and health first in disaster preparedness with respect to response. Persons can access those educational platforms to have the requisite information so that they're actually prepared in the event that there's an adverse event from one of the factors for climate change. There was a meeting as well with respect to CARICOM, PAHO, and other stakeholders that was hosted this year in particular that would have focused on revisiting the Caribbean Action Plan on Climate Change and Health. And that's supposed to be presented later this year. With respect to, I think it's the same meeting in November 13th, from that collective meeting with at least 14 member countries giving their perspective from both small island developing states, or SIDS as referred to, for example, the OECS, as well as other larger Caribbean islands, because there are about at least 23 to 26 islands and a few more that can speak to the fact that they're impacted by the elements. So as we spoke to those before, whether it be rising sea level, whether it be hurricanes, which is one that we're accustomed to experiencing during this time of the year, then that is something that they can access. There's another organization called the Healthy Caribbean Coalition that would have put together a booklet or a pamphlet, not necessarily specific to just cancer alone. However, it helps as a guidance or tool for persons living with non-communicable diseases, letting them know what items are important to have at hand in terms of assembling, medications, possible, keeping your records safe, even your hospital records. So if any need comes up for evacuation or movements, then those are available to clients based on the recommendations made from the Healthy Caribbean Coalition and PAHO. So.
Thank you. Naomi, similarly, are there any initiatives that connect climate awareness with cancer prevention or early detection in Ghana? I believe you're muted.
Sorry, there are not many, or will I say, explicitly linked to climate awareness and cancer prevention, but there are some relevant initiatives that are in Ghana. We touch on one or both and could serve as a foundation for, and I think it's the ripe area of nursing leadership innovation. We could have this climate change, the health project led by the Ministry of Health and the UNDP, which is saying that integrate climate change into the management of priority health risks in Ghana, including pilot district. We also, whilst cancer is not really the main focus, the framework of health systems and climate change provides useful tools for linking early detection and patient access, like say resilience. We also have the Health Vulnerability and Adaptation Climate Change Assessment by the WHO and the Ministry of Health in Ghana, which is looking at how climate risks affect the health system. Again, they are more general, but not skewed towards oncologists. So it's something that recently, just this week, the minister launched No Lead campaign, where we know that most of our water bodies have been polluted with lead and mercury. So he's led the No Lead campaign, making sure that this thing has to stop so that we have clean water bodies. And this probably are some of the will I say link in terms of cancer prevention later on, but there are no clear catalog. And it's something that we need. These are some of the, will I say, exposures for cancer to, cancer risks that needed to be looked at in terms of our water bodies, pollution in our water bodies, and air pollution. But it's something that is coming up. As far as now, we are having some lung cancers coming up. Those are some of the things that we have to look at, but there are no straightforward, will I say, programs towards climate change and cancer. Right.
Thank you. I have a couple of questions that I'm going to direct to all of you. So this first question is, what are some of the ways different regions can cross-collaborate to improve climate-resilient cancer care? And I'll start with Dr. Anderson on that question.
So I think drawing on experience between different regions is extremely important. I think one point that we could collaborate and share some experiences is through European Respiratory Society, which is the globally largest society of medical professionals working with lung diseases, chronic lung diseases and lung cancer. We have both from cancer care, from prevention and advocacy on clean air and climate mitigation adaptation, done a lot of work on directly impacting policy, gathering kind of the health lobby, serving the newest evidence on air pollution. For example, I mentioned the latest revision of European air pollution law, making sure that health really is a main driver of these environmental policies. We have made a statement, I had in my presentation, climate change statement. This was really widely cited and even mentioned in mainstream media, and a similar statement for clinicians. That's also very important for us. Something the clinicians could take in their clinic and dare to ask their patient. A lot of clinicians still don't have don't know how to address climate change and air pollution in their practice. For example, when we talk about lung cancer, air pollution is a second risk factor, but most clinicians working with lung cancer still don't address air pollution in their practice. I think everybody asks their patients about smoking history, but very few clinicians today ask about heating source at home, or distance to busy road, or distance to industrial site, or these are simple questions. So I think it's extremely important to educate clinicians as well in climate change. This is fast changing risk factors for cancer that we need to really provide continuous education. Most physicians working today did not have this in their medical curriculum. So I think I will draw on this power of medical professional societies and patient societies that have direct link to very many clinicians and patients, and draw on experiences, what worked, for example, in European Respiratory Society, what would work in American Lung Association, and do together a lot of these statements, or share our experiences of how you reach clinicians from US to Europe to Africa, Latin America. And try to reach some global partnerships and share materials and things that work. I think there's a lot of power of that in that. And together we would make much stronger voice for policy. First for patients and patient care, that's priority, but also for pushing policy
out of Western
globally.
Michigan, a second round pick in 2024. He played in 11 games
Dr. Schiller.
as a rookie,
Yes.
but he then would cut short with me
The same question.
this season, and he fought his way back. His first
I'm
act,
sorry here, something happened to me.
incredible blocked punt for a touchdown on Monday.
Can you go to somebody else? I'm having a slight technical difficulty.
Dr. Nimrod, what are some ways different regions can
To say about his
cross-collaborate to improve
great
resilient cancer care?
Okay, so I think developing and launching a cancer and climate resilience educational module for patients and caregivers in the Caribbean, obviously with insight from other stakeholders, would be a great way to integrate early detection messaging and making that alignment in terms of, as we said, climate change and persons understanding, both the physicians and the patients, what the expectations are, looking for even for our top cancers, as we mentioned before, breast cancer, prostate, colon, gynecological cancer, and then putting in something like a disaster preparedness checklist, highlighting for the policymakers, the hospital administrators, facility access planning, and then lifestyle and environment risk awareness, because something that's also very important would be nutrition for cancer patients, which can be as well affected by climate change, the environment, and then if the disaster occurs, lack of access to adequate nutrition. I think adapting it in particular, for different languages, to have that community input would be important, and pretty much putting forward as iterated by all of the presenters before, a health sector climate resilience planning. Smart hospitals is something that had been discussed via some of the Caribbean stakeholder meetings before, to ensure that cancer care is explicitly included in this disaster preparedness and continuity plan, and also looking at elements, for example, in terms of patient navigation, which is a very essential element for cancer patients, and a communication toolkit. So again, persons have access to either hotlines. I'm very interested in AI innovation and ensuring, that there's some sort of app available or design so persons have the opportunity to navigate same. And then again, templates that can be shared so persons have the opportunity to look for rapid outreach or relief as we, work towards this global climate resilience portfolio.
Thank you. And Naomi, how can different regions collaborate in Africa?
All right, thank you very much. I think one of the clearest lessons that we've learned in Africa that there's no one single region that can build climate resilience cancer care alone. And our challenge is whether it's flooding within West Africa, heat waves, whether in the north or drought, and they may look different on the surface, but they all could disrupt the same thing: access, supply chains, and workforce stability. So there should be, of course, collaboration, which can start quite simply, and we could use the AOTIC platform, which is quite big. All African countries who are within the cancer space usually are within those things. So we could share what works across. We could first take data with what are our existing data, identify whether patients in climate vulnerable areas presenting late for care. We build evidence to advocate for targeted resources. We could also share the works across regions, like those who have solar-powered chemotherapy fridges. How are they doing it? How can we also mobile screening units? Are there any nurse-led triage models that we all can learn from, which can save others from reinventing the wheel? And when one country finds a low cost like adaptation, then it keeps services running during extreme weather. That's knowledge worth sharing. And we also will need stronger regional platforms that will connect oncology teams, such as policymakers, networks like, as I mentioned, AOTIC, then the nursing, International Society of Nurses in Cancer Care, UICC, and the like. Even smaller nurse-led forums can serve as a bridges. They allow us to document what local teams are already doing, I think, quietly, and translating to regional guidance. As I said, doing a normal cancer preventive, let's say, awareness package. There's no, as the previous speaker said, there's no emergency preparedness in there. So it's something that has to be inculcated and infused, and we are having a review our cancer plan. So it's something that needs to be fed into it so that it will help us be able to be resilient in case we are having such shortfalls from the climate change. We could also, in terms of joint training programs, could also help between the West and Africa. We have, whether there's heat waves in North America, whether it's flooding in Africa, it's, at the end of the day, it's interrupting the same thing. So within countries or across continents, we could come together to join force and learn from each other, as I've said previously. Organizations, ASCO, ISMO, UICC, and the like, who has the Voices for Cancer, AOTIC Voices for Cancer, could also collaborate and send on one position statement for the various countries. I mean, their health ministers. There's going to be a cancer leaders meeting next year. So those are some of the places that together we could have a voice, and also infringe on or push for the health ministers to put into their various agendas when to drive. And finally, I will say that I think collaboration should include data, which I've said before, we should start pulling information on how climate is disrupting and affecting cancer outcome. Then we can advocate more powerfully for funding and policy attention. So in short, collaboration begins with sharing stories, solutions, and evidence across borders. And nurses being the link between patient and system are perfectly positioned to have or to start such conversations or to be included in such conversations. Thank you.
Thank you.
Yeah.
And Dr. Schiller, we have about 3 minutes left, so I'll come back
Okay.
to you and see if you have anything to add.
Well, I just wanted to address the question I thought I saw in the chat or the question and answer box regarding pharmacy, because that's not something we typically discuss, but it is obviously a big part of cancer care. And what can we do in terms of pharmaceutical drugs? And I think there is some stuff that we should be doing, one of which is simply, are we over-prescribing? Can we decrease the intervals, for example, between when we give the drugs? Or can we give more of them subcutaneously? Assuming, this is all assuming, of course, that different drugs have equal efficacy, but can we can we give them orally? I think another question, which I think some places in the world do, but we do not do here in the US, and that is share vials. In the US, if there's some amount of drug left over in the vial, it gets tossed. We should be able to share that with other similar vials and decrease waste in that regard. I think that another quick thing is what I think they call it dose banding. And what that is instead of the pharmacy making up 97 milligrams of something, can they make up either 95 or 100? Is that really going to make all that much difference? Because at 97, some of it's going to get wasted. So thank you.
Thank you. We're just about out of time, so I want to, first of all, thank all of our panelists for joining us today. This has been a very lively discussion, and I thank you for your time and your input. And with that, I'm going to hand this back to Matt Izzo for the closeout.
Hello, everyone. My name is Matt Izzo, and I am a specialist in global policy and strategic alliances at NCCN. Thank you all for joining us from across the world to discuss this important topic. I would like to thank the following organizations for the support of their webinar series. Without your support, we would not be able to have these important discussions. The recording for this webinar, as well as previous global policy webinars, can be found on our website, nccn.org, under the Global Policy section. We are excited to announce the 2026 Global Policy Webinar Series topics. The first topic is the growing cancer burden in young adults, and the second topic is oncology workforce shortages and the future of cancer care. Please be on the lookout for more information regarding these webinars soon. Thank you again for your time, and have a great rest of your day. Thank you.